afternoon, everybody, and welcome to the Life Unites Us July webinar. My name is Erica Saylor. I'm a research associate at Penn State Harrisburg, working as part of the Life Unites Us project. And today our webinar is going to be talking about the importance of recovery housing. So for today, I'm just going to go over a few items with Zoom, a little bit of overview of information about the campaign for any folks who are new here. I'm going to be introducing our moderator, who will then be taking care of our speaker introductions, and then speakers will be giving their presentations. We will have time for question and answer, and then we will wrap up. For anybody who does have any questions for our speakers, please feel free to put them in the question and answer, or the Q&A feature at any time during the presentation. We will, like I said, have time after all presenters go to answer any questions. The preference for us is the Q&A feature as opposed to the comments. So if you wouldn't mind putting them in there, that would be greatly appreciated. If for any reason during the webinar today you get disconnected, please retry your link from Zoom, the original link that you were sent, and you'll be let back in the meeting. If for any reason that doesn't seem to work, have no worries. The webinar is being recorded and will be posted to our Life Unites Us dashboard, so you can view at a later point in time if you would like. All right, so moving on to the campaign information. Life Unites Us is a project developed to reduce stigma around opioid and substance use disorder. This is done by using a people-forward approach that aims to connect individuals through stories. Through research and practice in anti-stigma work, we have found that connecting people through their stories and similarities can and will reduce stigma. In order to do this, the team records stories of community members across PA, stories of both personal recovery and as an ally to someone in recovery. Short stories are then produced and featured on the Life Unites Us website and on social media. The aim is that by sharing stories of hope and resiliency, we can prove that recovery is probable, reducing stigma makes recovery more likely, addiction is treatable, those living with an addiction are just like anyone else, and those living with OUD or SUD are much more than their disease. As I mentioned in the last slide, this campaign can be found online. The website features a library of resources that are shared across social media platforms. The main website is lifeunitesus.com, listed there on the slide. The campaign works alongside a variety of local partners to bring it to life. The aim is really to provide a platform for voices from all communities across the Commonwealth, and to be a resource to add to the work and many of you are already doing to end stigma. As I mentioned, something really great about this campaign is that you can join us in helping to end stigma by following and sharing the campaign information. And if you're part of a larger organization or effort, we would love to invite you to become a partner with Life Unites Us. Partners of the campaign have the opportunity to help recruit stories and share stories to and from your community. If you do sign up to be a partner, you can have your logo included on our website, receive curated campaign content and videos, be invited to our monthly webinars and trainings like today, get access to exclusive partner resources, and have input on what types of webinars and trainings we do next. If you're interested in becoming a partner, you can complete the partner form on the Life Unites Us page, or you can email Ashley Narvaez. Her email is on the slide currently. And we would also love to hear where everybody's joining us from. So if you're joining the webinar today, please feel free to say hi in the chat and put your name and where you're from as well. All right, and without further ado, I will introduce our moderator today. It is my pleasure to introduce Liz Donaghue. Liz is an addiction specialist for the Coordinated Homeless Outreach Center in Montgomery County. She received her bachelor's degree in psychology from Millersville University in 2013 and her master's degree in criminal justice from St. Joseph's University in 2016. She began working in social services as a resource coordinator with Resources for Human Development, working specifically with justice-involved individuals experiencing homelessness. In her current role, Liz works with individuals staying in Montgomery County's emergency shelter who are in recovery or actively using substances, and works closely with housing and homeless services in Montgomery County to develop housing and treatment plans for shelter residents. Liz, I will turn it over to you.
Yes, thank you so much. It's now my pleasure to introduce our first speaker today, Dr. Dan Mallinson. Dan received his PhD in political science from Pennsylvania State University. His expertise lies in state and local politics and policy, and his main research focus includes examining the mechanics of policy diffusion among U.S. states. Additional interests include public administration and public policy, as well as statistical methodology. He is particularly interested in Pennsylvania state politics and has experience as an information specialist for the Pennsylvania Public Utility Commission and as a program analyst for the Office of Inspector General in Philadelphia through the U.S. Department of Health and Human Services. Dan is published in a variety of journals, including Policy Studies Journal, State Politics and Policy Quarterly, State and Local Government Review, and Statistics, Policy, and Politics. He received the Robert S. Friedman Award for Excellence in Teaching from Penn State University and has published about pedagogy in political science and politics. Dan, thank you for joining us today, and I will hand it over to you now for your presentation.
Great, thank you, Liz. Let me share my screen. All right, and that looks good. All right, so as was mentioned, I'm Dan Mallinson. I'm at the School of Public Affairs here at Penn State Harrisburg, and my research is on, I'm a state and local politics scholar, but I study how states learn from each other, and I do a lot of my research in the area of health, particularly cannabis policy. But today, my role here is really just to set the stage for the rest of the speakers. I want to talk a little bit about housing as a social determinant of health and why housing is so important to people's health, and to really set the idea of why today's webinar is so important, and why the work that the rest of the panelists are doing is so important to the Commonwealth. So to set that stage, there. Yeah. It's always a little weird on Zoom. There we go. So there are a variety of what are called social determinants of health. The Healthy People 2030 captures them or sorts them into the 5 major categories that you see on your screen. And the federal government places housing as a determinant of people's health in the economic stability major category. But you can imagine that as you think about these other categories, healthcare and healthcare access, neighborhood and built environment, individual social context in their communities, and their access to education, including particularly K-12 education, housing really touches on all of these, right? And it's fundamental in many ways to people's stability and ability to access health and a healthy lifestyle, and to have a flourishing life. So examples of social determinants of health beyond housing include things like transportation, neighborhoods, racism, discrimination, education, job opportunities, pollution, access to nutritious foods, language and literacy skills, and things like that. But again, housing tends to touch on many of those other social determinants as well. As we narrow in on housing as a social determinant, housing relates to health outcomes and healthcare costs in a couple of different ways. So in individual stability, in the quality and safety of the housing that they have, the affordability of their housing, and in the neighborhood in particular. If we think of some of the specific ways that housing interacts with people's health, you can think of, for example, the quality and safety of housing, substandard housing. If housing has mold, has vermin living in the housing, there's inadequate heating and cooling. You know, we just had a major heat event in the United States as well as in Europe, and we're going to see those increase as climate change continues. Not having appropriate cooling can be a real significant health threat for individuals. Having water leaks, lead in water, lead in paint, all of those relate to the quality and safety of people's housing and how it can impact their health. Overcrowding it can be a challenge with housing, and that can contribute to disease transmission. Again, very familiar, and we're all very familiar with this now, as we are still in the midst of global COVID-19 pandemic. But other transmissible diseases will spread easier in housing that is overcrowded. Mental health and stress that comes from overcrowding, and that can include relational stress among families, can be a challenge. Reduced sleep when a home or a facility is overcrowded can also be a problem for people's health, right? And can lead to a variety of health problems. Housing costs and affordability is a challenge as the percentage of someone's income that goes to just having a house, having a place to live, or having housing, I should say, and a place to live, that crowds out other spending, including spending on primary care and preventative care. Foreclosure and eviction, stability in housing, right, can cause a variety of stresses, mental health stress, physical health stress. It's particularly challenging for children, and there's good evidence that children that have experienced multiple moves, which is defined as 3 or more moves in a year, so that's very unstable housing, that movement activity and the lack of stability will cause health problems for children. Foreclosure has also been associated with worsened health outcomes, including depression, anxiety, increased alcohol use, psychological distress, and suicide. So again, this connects to the stability portion of how having stable housing is important for people's health. Homelessness itself has lack of housing has a variety of physical and also mental and emotional effects. There are higher rates of chronic illness among the homeless, high rates of substance use disorder, increased risk of premature death. For individuals who are pregnant and homeless, there are increased risk of preterm delivery and low birth weight. There's higher rates of intimate partner violence. So again, all of these are reinforcing the idea that housing is a core social determinant of people's health, right? Having stable, quality, affordable housing in a neighborhood where you could build social connections is important to people's health. We're at a particular moment where housing is becoming affordable housing is becoming increasingly out of reach for many Americans. The map that you're showing, there's many different ways to illustrate this, of course, but the map that I chose to show on the screen is the hourly wage that would be required in each state based on its average housing costs to have an affordable, for housing to be considered affordable. And that definition is no more than 30% of your income. So what is the wage that you would have to make in each of these states so that the average housing cost would not be more than 30% of someone's income? You can see for Pennsylvania that would be $19.23 an hour. Pennsylvania is not the highest state. And there are much higher states like California, who has a major housing affordability crisis, New York, Florida, et cetera, but it's also not the lowest. If you look across all of these states, none of them have an hourly wage rate for affordable housing that is below that state's minimum wage. So that means that minimum wage workers in any state are not going to be achieving what we would consider to be affordable housing in terms of the percentage of their income. So this is a problem that is, unfortunately, in the current trajectory, getting worse and going to continue to get worse in many states. And the current inflation and housing crunch has really ramped that up. But it was a phenomenon that was occurring before the current economic moment, and will continue. One of the things I want to touch on just briefly is the policy landscape. We're going to hear a lot about state and local policy here today from the other speakers, so I'm not going to spend a lot of time on that, but I did want to note some of the federal policy landscape because it is important in this particular issue. So this doesn't capture all of the policies, but some of the major ones. The Fair Housing Act of 1968, the Equal Credit Opportunity Act of 74, they both prohibit discrimination in housing and renting and selling based on race, sex, and other personal characteristics. I'm going to circle back to that in a moment. The Community Reinvestment Act of 1977 requires banks to take actions to increase their lending to low and moderate income neighborhoods. And this was an effort to try to reverse the effects of redlining. Unfortunately, there's a lot of good evidence that redlining, while not a formal policy in terms of dictating where people can live, is still very much alive today in dictating where folks live. Other programs that have been implemented to aid in making housing affordable include public housing that's built actually by the government, right? There's about 1 million federally owned public housing units across the country. There's also ongoing provision of federal funds to public housing agencies. But this has been underfunded. One estimate is that there's roughly $45 billion worth of maintenance that is outstanding at these federally owned public housing facilities. And then, of course, there's also Section 8 vouchers. These are used to help afford rent in the private market. Also a program that is both underfunded and underutilized. One estimate is that roughly 26% of eligible households actually receive federal housing subsidies. But even with that low level of use and access, there's roughly 3.3 million people in the US that use Section 8 vouchers for housing. There's also been the introduction of low-income housing tax credits that are an incentive to build new low-income housing. There's roughly 2 million of those units that have qualified across the country. But again, I mentioned this earlier, in states like California and really across the United States, there is a distinct lack of access to affordable housing. And these market-based incentives have not completely filled that gap. So there are a lot of continuing policy challenges at the federal level, but also certainly at the state level and local. The one last piece that I wanted to touch on, this comes from some of my work on cannabis, but also relates to what some folks are going to talk about in the rest of the webinar. There's important linkages between incarceration, addiction, and housing, and all of these have impacts on people's health. So there are special challenges for those who have been part of the criminal justice system, who have been convicted of drug crimes or other crimes. They are typically banned from accessing public housing. There is variation allowed for that, those rules, but public housing authorities tend to be fairly restrictive on this account, and anyone currently using a substance would not be allowed access to public housing, and also other public benefits, can lose other public benefits like food stamps and Section 8 housing and things like that. And so this can create a cycle of unhousing that can lead to interaction with the criminal justice system that then can lead to unhousing, that can be a problematic cycle, and is particularly problematic for those who experience addiction to their substance abuse. We're going to see from or hear from speakers in the webinar about other housing options that are available to try to break this cycle. There have been some reforms federally to try to proposed to change public housing rules. There was one that actually just failed, unfortunately, this week, that would have carved out cannabis users from the restriction on current drug users from accessing public housing. It's notable that we're in a state that has medical marijuana, and that does not, the state legal use of marijuana, whether medical or recreational, still disqualifies someone from accessing federal public housing and housing benefits. So there's a lot of ways in which states are having to step in and make up that gap. So with that, I'd like to pass it back and pass it forward to our speakers that will talk about specific initiatives that they're working on in the area of housing.
Thank you so much, Dan, for your presentation and insight into housing as a social determinant of health. If anyone has any questions for Dan specifically, please put them in the Q&A feature at your convenience, and they will be addressed at the end of everybody's presentations today. Our next speaker is Kathleen Jiorle. Kathy currently serves as the Northampton SCA Administrator. She's a graduate of DeSales University, majoring in criminal justice, and has worked in the human services field since 2005. She started her career at Northampton Children and Youth Services in 2005. She, as a caseworker in the adolescent unit, and left there in 2018 as a supervisor in the General Protective Services area. Kathy has been working in the drug and alcohol field since 2018 and started as the Northampton SCA Assistant Administrator before moving to Administrator in May 2022. During her tenure, they've implemented many new programs and services and work closely with providers to ensure that the residents of Northampton County have the services that they need. Kathy, I will turn it over to you now for your presentation.
Thank you, Liz. All right, I'll try to. All right, so I'm going to talk a little bit about the Northampton County program just briefly. This is one of the many programs that are grant funded by DDAP to address the issue of homelessness and those who are in recovery and dealing with affordable housing. So our program here in Northampton County is just one of the many programs available throughout the state, and each program is tailored a little bit differently. So ours is called the HERO program. HERO stands for Housing Emergency Response to Opioids, and you'll hear me refer to the name HERO a lot, as that is what we call it. So our vision statement with the HERO program is that we wanted to expand transitional housing case management services to provide rental assistance to those who are eligible, who are persons in recovery. So we aim to have each person in recovery obtain safe and affordable housing to prevent or divert them from homelessness. So that is our main focus. We have, as part of our program, a case manager and a CRS that work together to provide recovery support and case management services that assist the person in recovery with eliminating barriers to treatment and housing. Our rental assistance is available for those who meet criteria and remain
Kathy,
engaged.
I hate to interrupt. I hate to interrupt you. I'm so sorry. For some reason, we're still just seeing like it's just the PowerPoint. Your slides aren't advancing at all.
Oh, okay. My face is over here. Okay, so I went through our vision statement with what our HERO program is all about. So let me just get into the program goals. So our goal initially when we wrote the grant to DDAP was to target 35 individuals in recovery. And we thought that was a really ambitious goal to get 35 people into housing. So we have had this program for probably 2 years now, and we have served over 300 individuals. Now, what that means is that we haven't gotten 300 people necessarily in new apartments, but we've tried to provide them with as many services as possible so that they could obtain public housing, obtain recovery housing, obtain a more permanent situation than what they came from, right? So not every one of those 300 has an individual apartment, but they have more permanent housing than when they started in the program. Initially, our program had 1 case manager and 3 CRSs. We then quickly expanded that to 2 case managers and 3 CRSs as we saw the need of the program grow. The SCA case managers here complete the initial assessment for those identified as coming in and wanting the HERO program. They determine eligibility, and then they pass along to our provider staff who do the ongoing case management for the program. Our provider staff meet with individuals and they meet with them at, they meet with the individuals who are those persons in recovery who have been identified for the program, and they meet with those at one of our 5 county recovery centers. The funding for the HERO program is not guaranteed in that individuals must comply with the program and the requirements to be eligible to continue to receive funding. So if you have someone in the program who's not meeting with their case manager, CRS, et cetera, they will not be guaranteed funding because they are not participating in the program as it is outlined. Funding requests are reviewed by the team so that we can ensure the most appropriate use of our HERO funding, which is limited. And then I'll go on to our program structure. So our case managers have specific tasks, which I'm not going to bore you with reading each one of them. And then our CRSs also have assigned tasks. So some of those tasks would be, case managers meet with our clients weekly, they develop budgets, they assist with verifying income and obtaining employment, they help clients search for housing, those type of things. Ideally, if we have a client who is struggling with relapse, needs additional treatment, the case manager will point that person and get them assessed and into treatment if there is a relapse that has occurred. This is unique in that if someone has identified in the program that they are struggling or they have relapsed, we will pay to their bed or hold their apartment so that they don't lose housing once they go into treatment. This is a way that we can ensure people are getting the treatment that they need and they don't have to worry about becoming homeless as a result of their substance use. We also require that our clients meet with CRSs. So they meet weekly, they locate self-help meetings, they conduct groups at the recovery houses, and they assist clients who are not currently in recovery housing to gravitate towards recovery housing because there's individuals with like experiences at those recovery houses. Client requirements. So we've changed our program a little bit over the years because we've discovered that by just giving persons in recovery everything that they could want or need, some feel a little more entitled than others. And we wanted to keep the integrity of the program and not run out of money, right? Ideally, because there is not an endless amount of funds for this program. So some of our client requirements, which are a little newer, some have been in place since the beginning, but some are a little newer. The client must keep track of when their rent is due, and they're responsible for submitting the funding request and justification to our case manager in a timely manner. So if a client realizes that it is the 30th of the month and their rent is due on the 1st and they have not submitted any paperwork to their case manager, it is very likely that their rent is going to be late and they are going to have to pay a late fee. We do everything we can to expedite things, but clients need to be responsible. Other individuals have to be responsible for when their bills and rent are due. And certainly if they're having difficulty, their case manager can work with them on understanding budgets and timelines and paying things prior to a due date. Clients must keep in contact and meet with their case manager and CRS. If they have an extended loss of contact, that could lead to them being disqualified from the program. Clients must demonstrate a desire to remain in recovery and seek assistance when they are struggling. And that goes back to, if you relapse and you get treatment, we will continue to pay for your housing. Clients are required to perform 4 hours of community service monthly. The input and feedback that we are getting is that they need to have, clients need to have a buy-in, right? This can't just be a program where they just are handed money and they have no buy-in. So the 4 hours of community service gives them part of that buy-in that they need to stay on track. Clients are placed on a tier system for funding based on their financial need. Need is determined based on employment status, their time in recovery, and financial verification. So someone new to the program, for example, would be on a tier 1. Tier 1 is we fund your rent 100%. Tier 2 would be we fund your rent 75%, and then so on, tier 3, tier 4. Ideally, the further away from getting out of treatment, the more you're making, the more likely you are gainfully employed, and you have some things, more, you're more put together, and you have some more things going in your favor. We do have several partners that we use with our HERO program. So some of those are Treatment Trends, EmpowerWorks, Victory House. Those are some of our providers that do fiscal management, CRS, and case management. EmpowerWorks is our recovery housing. And then we have various other treatment providers. We don't specifically use only one treatment provider to refer clients back to inpatient, outpatient if there is a need or if there is a relapse. Anyone who can meet the need of the client is who we send to. We just make sure that we work hand in hand with our case managers and getting those folks into treatment as quickly as possible. So with that, that is my quick little blurb about Northampton County programs. So I will turn it back over to Liz.
Thank you so much, Kathy, for your presentation on the HERO program. That sounds incredible. If anyone has any questions for Kathy, again, please put them in the Q&A feature, and then we will be going through questions at the end. Our next speaker is Emily Leidhecker. Emily is a case manager supervisor with West Branch Drug and Alcohol. Emily graduated with a Bachelor of Arts in Criminology from the Indiana University of Pennsylvania. She's been employed with West Branch Drug and Alcohol for 7 years, and among other duties, she oversees West Branch's jail to treatment and rental assistance programs, along with managing a high-intensity caseload. Emily, I'll turn it over to you for your presentation.
Okay, so I'm from West Branch Drug and Alcohol Abuse Commission. We serve Lycoming and Clinton counties in Pennsylvania. Our SOAR housing initiative started in March of 2021. Prior to that, we had been a smaller housing program where we used health choice funding, that anyone that had the health choice insurance could get a security deposit and kind of that lump sum payment to move in. Since receiving the SOAR housing grant, it's expanded it's gotten much bigger than we anticipated. So we have served approximately 430 individuals since it started in we got the grant in February, and we actually, I think, served our first individual in March of 2021. So anyone who is seeking rental assistance can walk into our office. They have to be open and active with us. In order to do that, they need to complete the screening and assessment process, and then they need to follow any treatment recommendations we make. So if they have a opioid use disorder, stimulant use disorder, that makes them appropriate for the SOAR housing funding. If they do not have one of those diagnoses, we can sometimes pull from other funding to help with housing, but the majority of our funding does come from the SOAR housing grant that serves the opioid use disorder and the stimulant use disorder. Sometimes people come in and they are in remission, so they do not need to do treatment. They're not recommended for treatment because they've already done it and they've had a large amount of recovery time. They are required to do case management services if they're not recommended for treatment. They have to complete a GIPRA assessment and then agree to do a follow-up GIPRA within 6 months in order to continue receiving funding from us. Sometimes people come in and they need the inpatient treatment. Those individuals who have housing and are worried about losing that housing if they go inpatient, we explain to them, if you're agreeable to our recommendations and we find a bed for you in an inpatient facility, we can pay your rent while you're there so you have a place to come home to. Our housing grant started with basically doing the lump sum payment with the security first and last month's rent. And then we were able to pay up to 5 months of rent for those individuals. We kind of stopped broadcasting that because we've been noticing, kind of like Kathy said, that people were kind of showing up and expecting to get these months and months of rent, but they weren't really doing much in order to maintain their housing. They were just expecting the housing funds to come from us. Kind of what we did to help prevent that is start like a housing case manager position. I'm kind of bouncing around here, but so our housing case management services include a housing case manager who is designated to complete the assessments on those seeking services and complete the GIPRA. And then she's also doing all the rental agreements with our landlords. Over the last year and a half, we've established relationships with over 40 landlords in our community. There's a handful of them that are in constant communication with us. And we even hand those like a list out to individuals who are currently homeless, are seeking an apartment or a room for rent, and they don't have any prospects. We hand them out our landlord list so that they can reach out, call the landlord and say, you know, I'm trying to work with West Branch, trying to get some funding. And then also on the other side of that is the community resources, like our local homeless shelters. You know, Brittany, who is our housing case manager, will explain to them that you need to reach out to American Rescue Workers. And there's also STEP that offer housing program assistance as well. In order to get our housing assistance, you have to show that you have tried other options before that we are able to pay your rent. The other housing case manager that we have, so Brittany kind of does like the paperwork side, the rental assistance agreements, you know, works with our CFO to get the checks in place, and she does do that initial assessment with people seeking housing. On the other side, we've recently had a part-time housing case manager that's taking more of our intensive cases. So people that we've put into housing and, you know, we're concerned about their mental health, we're concerned about their sobriety. She is meeting with them weekly to make sure that they're staying on track so that they can sustain their housing. Part of what we provide in our housing program is, you know, that initial lump sum payment, the last month's rent. And like I said, we can do up to 5 months of rent for individuals who are showing that they're actually trying. You know, we can't just have you living in an apartment and us continue to pay your rent if you're not in treatment and you're not trying to seek employment. The intensive housing case manager can take them to our career link. She can meet them at their apartment and see how they're doing. So she just started, so we're kind of just working that program out where she's actually meeting people where they are and helping them to sustain their housing. So the other part of our rental assistance program, we do up to $1,000 of back rent. So anyone who's facing an eviction or they're just behind in their rent, they can come and, you know, request services for us to pay their back rent up to $1,000. And then we also do the utilities. So we can do up to $500, excuse me, in utility assistance. We've paid electric bills, phone bills. We've even, you know, bought propane for an individual at one point during the winter. So in the 430 individuals that we have served, that was strictly for the rental assistance. We've actually had people come in who don't really need rent. They just need help paying their PP&L bill or their UGI bill. Still have to go through the same process of the assessment and recommendations for treatment, but we, you know, if we don't pay their rent, but we help them pay their PP&L bill. The other part of our housing program is the emergency housing. So we can do up to 7 days of shelter in a local hotel. The issue with that is you have to have a plan in place after those 7 days. So if someone comes to us and says, you know, I have a lease, I have an apartment, I can't move in till the 1st, you know, today being July 27th, we could pay for those couple days in a hotel for them, knowing that come August 1st, they're going to move into a place. We haven't been able to have people come and say, you know, I don't have anywhere to go. Can you please put me in a hotel? With no plan in place, we aren't able to use that funding to help them. Now, of course, there's always exceptions to that. If we have a pregnant female or women with children, sometimes we will see what we can do to put them in a hotel in hopes that they will get into a homeless shelter following that hotel stay. So the barriers to the housing program is the lack of available stable housing. So we have, you know, the landlords, like I said, we have a handful of landlords that we work with on a routine basis. The issue is they don't always have availability. We have people that are constantly looking for places. They can't find anything, especially affordable. So if we have someone, especially who's on Social Security benefits and they get $850 a month in rent, and they come to us saying, you know, I found a place that's $800 a month. Of course, we're going to explain to them that the idea of this program is to put you in somewhere that you're able to sustain it. We're not going to set you up for failure, you know, and pay for a couple months rent for you. And then when it's over, say, you know, you got to move out. So the criminal history, prior evictions, outstanding utility balances is always a struggle too, because we have landlords that don't want to rent. If you have, you know, that felony convictions, prior evictions, outstanding balances. Now that handful of landlords I was talking about, they kind of overlook this stuff. They, you know, they accept people with the felony convictions and prior evictions, and they've been really great with working with us to get these people housed. That was it. I'm just thinking of what else I missed that I could go over. I think I kind of skipped over the individuals that we serve. So if we have someone who is incarcerated and has nowhere to go, in the beginning of this program, we kind of helped them find housing in the hopes that they would do like the jail to treatment program. And then we would help them find a place for when they return. And the issue with that was we started it and it worked, but then it became overwhelming. There were too many people who were incarcerated who had absolutely nowhere to go. They had no employment history, and they were getting out, and we were funding rent, and it was kind of like a dead end. They would use the 5 months and then they would have to be evicted or find a new place to go. Our local homeless shelters are great with working with us when we say, hey, you know, we have this guy, we're working with him, he has nowhere to go. You know, can we get a cot set up for him until we find him a place to go? Our Saving Grace homeless shelter will reserve, depending on their space, sometimes they'll reserve like 2 cots for West Branch that if we call and explain the situation, they will make an exception to bring those people in, especially if we tell them there's a availability at some point for them to have some housing. So that's kind of just our overall rental assistance program. I was looking at Kathy's and thinking that the community service thing is pretty cool. So yeah, we're always making changes as the more and more people that come in. And I did kind of skip over the first slide that says we are spending about $40,000+ a month on rental assistance currently. But yeah, that's about all I have as an overview of our rental assistance program.
Thank you so much, Emily. Thank you for your presentation. I was also thinking the community service was really cool. But I think all of these services are so important. We have one last speaker today, and that is Fred Burke. Fred has been working for the Pennsylvania Department of Drug and Alcohol Program for approximately 7 years in the Bureau of Program Licensure. He has MHS in counseling and has a wide range of experience, including counseling, clinical supervision, and working with co-occurring disorders. His experience at GDAP started as a drug and alcohol licensing specialist. He was then promoted to drug and alcohol program representative and later transitioned into a position as a recovery house licensing specialist supervisor. Fred currently assists with the oversight of the recovery house licensing unit, within the Bureau of Program Licensure Division of Licensing Operations, where he supervises application processes, provides technical assistance, and manages licensing associated with recovery houses. Fred, I will turn it over to you for your presentation.
Okay, thank you. Let's see if I can get the screen to share correctly. Okay, my name is Fred Burke. I work for the Pennsylvania Department of Drug and Alcohol Programs. I'm going to talk about recovery houses. I am the Recovery House Licensed and Specialist Supervisor. Okay, so with recovery houses in 2017, the department was directed to create regulations for licensed recovery houses, especially the ones that are publicly funded or referred. Okay, so I'm going to review some policies and procedures that are required for the recovery house. And the purpose of the regulations is to make sure that the recovery houses are safe and that they do what they're supposed to do, which is provide a place for individuals leaving treatment most of the time to transition back into the community. As a recovery person myself, I realized that there are many opportunities to have housing that would be necessary, because once you go through treatment, there's not, or you cannot always go back to where you came from. A lot of people housing is not a safe place for them. There are people who are coming from the prison system going into treatment, and they also don't have a place to go. So recovery houses become important because it's a place, a safe place for you to be able to transition from treatment back into the community. These policies and procedures were written as an outcry from the public because recovery houses were all over the place, and they were able to take advantage of this population, and that was starting to show up everywhere. So I think that's played a major role in why the department was to write these regulations so that the recovery houses can present themselves with policies and procedures that they need to follow so that we can help them maintain a safe environment. I just picked out a few, but if you're interested in all the regulations, you can go to our website, and they're the 717 regulations for recovery houses. The ones that I'm going to review right quick are just standard ones for making sure that the recovery house is a safe environment and that they are continuing to do what's necessary for them to help the resident to transition back into the community. So the first one is they have the right policies and procedures on ensuring that residents are informed of the house rules. That's important because that means that the resident is aware of what's necessary for them to do to be able to stay in recovery houses, so they won't be getting evicted from the houses for rules and regulations that they're not aware of. The funding management, they have the right policies and procedures on being able to monitor everything, that every reaction, funding reaction that happens between the resident and the recovery house needs to be documented so that when we're doing inspections, we're able to identify that there's that their funding practices are up to standards. Everyone who works or volunteers for the recovery house has to have a criminal background check, a Pennsylvania state criminal background check, so that we are aware of their criminal history. Residents need to be able to participate in treatment. So if they are still in some form of treatment, outpatient treatment, but they couldn't return home for whatever the reason are, they need to participate in that outpatient treatment program. And also recovery supports, NA meetings, AA meetings, any 12-step support that they need, or any type of support that they have, because all support is not 12-step support, but whatever support is working for that individual, they need to be able to show that they are receiving recovery supports while they're in the recovery house. The residents have to abstain from drug and alcohol. This policy and procedure will show us what takes place if an individual does not abstain, and the safety precautions that recovery houses are using with those individuals while referring them back into treatment, if that's what they expect to do. If not, we just need to know what the process will be for individuals who are not able to abstain from drug and alcohol. The medication use and security is about anybody that's prescribed medication in the recovery house first not being discriminated against. And also, if you are an MAT resident, you can and are prescribed opiate medications for your treatment, you can be in a recovery house, and as well, you should have security for your medications so that no one is able to get to them except for you. So that protects all the residents in the house, as well as the individual who is on the medicated assisted treatment. Maintenance of the house, fire equipment. So all smoke detectors, carbon monoxide detectors, and fire extinguishers that are required in the regulation, we make sure that those are kept up to date and continue to work properly. So that if anything happens with any of those entities in the recovery house, you'll be able to make sure that all residents and volunteers and staff are able to leave the house promptly. Prohibit or requiring residents to relinquish public assistance benefits. So they have the right policies and procedures according to the regulation, which says that you can't have an individual that you can't make them sign anything to relinquish their public assistance benefits or their paycheck. So individuals will learn how to be able to be responsible for their money, and then even if they have food stamps, they would have to make the decisions based upon what they want to do with those food stamps. The recovery houses cannot make them relinquish their funding. The complaint management is for the resident, for the resident's family members, and also for community members. They have to write policies and procedures on how individuals can make complaints against the recovery house if necessary, and also how they can make complaints and let us know, the department know, and become aware of those complaints. And the emergency contact notification is for individuals who are supposed to return to the recovery house and they don't. Individuals who may be in the hospital, individuals who may have passed away or overdose, anything that's of an emergency of nature that you would need to let the emergency contact person know about. You have with 12 hours is according to the regulation to make sure that if any of those things occur, that there is someone aware of that, the emergency contact person is aware that the resident is experiencing any of those things. So all of these policies and procedures that I just went over that they would have to write, all of it is based upon things that have occurred in recovery houses. We want to make sure that they're safe. And somebody was talking about other things that can affect houses. We want to make sure that everything that the house needs in order for the residents to be able to safely transition into the community, because usually treatment is such a short period of time. That is not enough time for a resident that may need extended time away from their neighborhood in order for them to stay clean and sober. So the recovery house, that's what they do. And we just want to make sure that the resident is covered, protected, and safe. So the recovery houses, we begin to take applications for recovery houses to be licensed in December of 2020. But I believe the first one we really got was in February. So right now we have over 100 recovery houses licensed in the Commonwealth of Pennsylvania. We are working over 100 applications right now, formally to license recovery houses, other recovery houses. And I think we have over 100 applications that are being worked on so that they could be submitted to be licensed recovery houses. So in order, if you are a federal or state funded recovery house, you need to apply for license. If you're receiving referrals from public funded facilities, you need to apply for a license. And if you're getting referrals for individuals in treatment that is funded by federal and state funding, you would also need to apply for drug and alcohol license for recovery houses in the Commonwealth of Pennsylvania. So any federally funded or state funded entity needs to apply to be licensed. So our website will be on the slide presentation if you want to go and find out more about the 717 regulations and what the recovery houses need to write policies and procedures on. And we also have a Facebook and Twitter page. That information is on there. And if you are a recovery house in the Commonwealth of Pennsylvania interested in becoming licensed, my email address is on here. You can feel free to contact me at any time for guidance. We also have a workshop that we provide for all providers on a monthly basis to assist you with filling out your application on a portal and making sure that all your policies and procedures are written correctly. So if you need to learn anything about applying for a recovery house, we have many different ways to assist you in that avenue. And so with that, I'll turn it back over to Liz.
Thank you, Fred. And again, if anybody has any questions for Fred or any of our presenters, please direct them to the Q&A feature now. Thank you to all of our presenters today for their expertise and insightful presentations on these topics. We will now move into the question portion of the session. We're going to begin to go down through questions. Our first question is for Fred. How can we encourage recovery house owners to get licensed?
I spent a great deal of time doing that because regulations are difficult for individuals that's never had the right policies and procedures on them. However, the regulations are created to not only protect the resident, but to protect the recovery house owner. Also, there's some funding and grants and different things they can receive if they decide that they want to become a licensed recovery house in the Commonwealth of Pennsylvania. And I think it's really important to know that the majority of all drug and alcohol facilities in the Commonwealth of Pennsylvania are licensed through us, because if you're going to do drug and alcohol treatment, you have to be licensed through us, and many of them will be federally and state funded. So in order to receive referrals from them, then you would have to obtain a license in the Commonwealth of Pennsylvania. So all of those things are important. And myself, being experienced, like I said, long-term recovery, I would work tremendously hard with any provider that wanted to do that, because the idea is to make sure that the residents have a healthy place to live while they're transitioning back into the community. And I believe that most people who have recovery houses, that's the purpose for them getting a recovery house in the first place.
Awesome. Thank you. Our next question is for Emily or Kathy, or if you both want to chime in. For others looking to start or expand housing programs for those in recovery, what advice would you guys give?
So for us, we had no idea, right? So we just kind of started with a couple of people in a room, kind of gathering some ideas, and we really looked at the needs of our community. So we talked to people in recovery, we identified what the need was, and we started small, which is why we started with one case manager, a couple CRSs, and really a lot of those 3 CRSs, like they were all part-time initially, like, because we didn't know, and initially it was really hard to get referrals because people didn't know what you were creating. So I would say find out what the community needs, start small, and then work from there.
I agree with Kathy. When we started, it was very, very small, and it exploded very, very quickly because, everyone says, oh, go to West Branch, they'll help you do this, they'll help you do that. So it was start small and start what you're actually going to do early, like make your roles. I mean, I love Kathy's, your community service thing. That's a great way for someone who is in housing and we're paying the rent and they're not working yet to just spend, 4 hours is not a lot of time to dedicate to community service when your rent's being paid. Kind of set those rules up, what you guys are willing to do before you release it to the community, because once it's released, the referrals are going to explode and come in. So it's, of course you have to change as it grows, but make sure before you start that you have everything in place that you want to see the participants do, because it does get very big very fast.
Absolutely, yeah. I think especially when you're dealing with rental assistance and you're dealing, with programs that are actually going to help with housing, since that's such a high need right now. Okay, we are almost at time. I'm going to hand it back to Emily to wrap things up. And thank you to our panelists, and thank you also to our attendees for joining today.
Thanks, Liz. I just want to thank again everybody for joining, and thank Liz for moderating today's webinar. I do just want to give everybody a heads up that when you close out of the webinar today, you will be directed to a survey. It should only take 1 or 2 minutes to complete. But if you have the time, we would love to hear your feedback on today's webinar and anything that we can do to improve the experience for future webinars, or even ideas that you have for future webinars. So again, thanks to all who attended today, and a special thanks to all our panelists and our moderator. And I hope everybody has a great rest of their day. Take care.